This is PopHealth Week on Healthcare Now Radio. I'm co-host and executive producer Gregg Masters, and I proudly serve as the managing director of Health Innovation Media, a digital media agency producing and curating original content for healthcare organizations, health systems, medical groups, physician networks, and the ecosystem of vendors and suppliers intent upon supporting their transformational missions. Joining me in the virtual studio is PopHealth Week co-founder and principal co-host, the one and only Fred Goldstein, who also wears the hat of president at Accountable Health, LLC. PopHealth Week is your go-to platform for lively conversations where industry leaders and stakeholders from all corners, including payers, providers, patients, vendors, and the regulatory community, come together to swap the best ideas and strategies in population health. To get in touch with us, swing by www.popupstudio.productions, or why not drop me a direct message on Twitter. I'm Gregg Masters, MPH, and that is Gregg with 2 G's. You can also reach out direct to Fred via @FSGoldstein or via www.accountablehealthllc.com. Today, we have an expert in pediatric value-based care and quality in the company of Dr. Jared Capouya, the Chief Quality and Patient Safety Officer at Nemours Children's Health. And with no further ado, let's hand the mic over to the one and only Fred.
Thanks so much, Gregg, and Dr. Capouya. Welcome to PopHealth Week.
Thank you for inviting me. It's great.
It's a pleasure to have you on. A topic we really haven't delved into much, which is children, et cetera. But why don't we start with, give us a little sense of your background and where you're working.
Sure. So I'm a pediatrician by training. I trained over at the University of South Florida here in Florida as a general pediatrician. I've worked most of my career as a pediatric hospitalist. Have spent about 10 years cumulatively on the West Coast of the United States as both a pediatric hospitalist, and that's where I got into quality and safety, really in a children's hospital setting. In 2018, went to Arkansas and was the vice president of quality and safety at Arkansas Children's, and that's where I continued some work in the population health space. I was also the medical director of the clinically integrated network for Arkansas Children's, which is Arkansas Children's Care Network, before moving back to Florida with my wife this past year. I've been at Nemours Children's Health now for about a year in Orlando, Florida. And I am the Chief Quality Safety Officer for Nemours Children's Health in Florida, and also continue to work occasionally as a pediatric hospitalist.
And can you give us a little background on Nemours?
Oh, sure. So Nemours is a multi-state academic institution that really focuses on the health of children. So our vision is creating the healthiest generation of children. We've got multiple children's hospitals, one in Delaware, so one in Wilmington, Delaware, which is about a 260-bed children's hospital, quite a large operation up there. In Florida, we have the children's hospital situated here in Orlando. It's a 130-bed children's hospital, quite a swath of specialty care across Central Florida, as well as primary care, and then also multi-specialty care centers in Jacksonville that also interact with Wolfson Children's, part of the Baptist Health System, and then in Pensacola as well, and then places in between. So really trying to take care of and deliver really high quality care to as many children in Florida as we can.
So a multi-state children's hospital company with clinics, et cetera, and
Yes.
really a broad swath of services. When we think about children, it really doesn't tend to hit the radar as much for payers or employers. You talked a little about the clinically integrated network you worked in Arkansas. Why is that, and where are we with the move to value-based care or efforts to try to do that with children?
Yeah, it's interesting. I saw a quote in Florida, and it said, Florida has a limited strategy to embrace value-based payment in the state Medicaid program. And I think maybe that exists in a lot of places, right? And maybe one of the reasons is, when you think about it, children don't account for a large cost in the overall healthcare expenditure, right? Children probably account for somewhere between 9 and 10% of the overall, what is it, $3 or $4 trillion that's spent every year on healthcare. And so there's probably an emphasis or essentially bigger fish to fry, right, in terms of trying to more in an immediacy or immediate standpoint to reduce cost. I think also one of the things that we've talked about a lot, at least when I was in the clinically integrated network before then too, was that, an investment in early childhood, or even if you take it back to when the child's not even born yet, it takes 18 years to see the payoff, right? And so there's no immediate return on investment, although there are probably smaller return on investments over time, investing in primary prevention from day one or day zero versus trying to take an entire population that's already very costly and trying to drive down some of the costs to try to get the benefit there. So I think there's a couple probably reasons there that the focus just hasn't been there maybe.
And do you see places where like a difference between perhaps Delaware and Florida and how they look at children and value-based care, things like that?
Yeah, in my time in Arkansas, they had moved to really managed care in the behavioral health population, and with our clinically integrated network, really focusing on value-based contracts within those populations, because they obviously are somewhat costly in terms of the sort of the breadth of children. When I was in Washington State, there was also a big move there by the healthcare authority, so the sort of the body that funds the managed care organizations from the state. A big movement to really move towards value-based payments and incentives for primary prevention measures. And I think there are some places that probably have gotten ahead of the curve a little bit more so than where we are currently in Florida.
And when you talk about it, I think about it from a population health approach and think, wow, we move way upstream, which is started day zero or pre, and the impact could potentially be enormous. We know about the disparities we see in birth outcomes and infant mortality, et cetera. So it really seems to be an area that would resonate. And you would think with children, naturally there's this natural care for children. And so it's sort of fascinating. We haven't moved in that direction as much as I would assume we could.
Yeah, it's interesting to me because exactly what you just said, there are programs out there, early childhood programs. So one that I was familiar with that we implemented in the state of Arkansas, but it's been implemented in New York and Colorado. It's called Healthy Steps. And really it's a focus of holistic care in the ages of 0 to 3, focusing on not just the child, but also the parents, and making sure that the parents are healthy, making sure that the child is healthy. And what they've shown is actually by doing that, you actually space out the time between births, right? So your birth spaces out. Parents tend to have a more positive experience in parenting. There's a lot of anecdotes that we used to get from parents, whether they had substance use disorders or other things, where there was a lot of impact on their life by having those resources embedded within a primary care clinic to manage not only the child, but also to help them with the coping and the parenting skills. And as a result, there is, in that case, an immediate return on investment, right, for every dollar spent. So I think states like Arkansas, who now provide, I think their Medicaid program, if you're enrolled in the patient-centered medical home program within Medicaid, they will actually provide you an incentive payment if you are enrolled in one of these early childhood programs like Healthy Steps.
Little behavioral economics
to
impact individuals. That's fantastic. You talked about the clinically integrated network, and was that mostly from a clinical perspective, or were there some value-based things like based on clinical outcomes or some financial risk associated with that?
There was no risk. It was all upside, and it was mostly. You're right. It was mostly clinical measures. So there were some care management type measures. There were some medication reconciliation type things, vaccinations, childcare visit rates, adherence to clinical pathways, whether it be asthma or bronchiolitis, something that's very common. There were some outcomes like chest X-ray utilization and use of different kinds of medications that there were incentives built in, sort of tiered incentives built in if those measures were met.
Do you think that the newer biologics, gene therapies, et cetera, that are coming out now for children are going to perhaps put more of an eye on looking at this as something we need to begin to focus on potentially?
I hope so. I mean, many of those are very expensive, right?
Yes.
They're in the multiples of millions of dollars. But when you think about it, you spend $2 or $3 million on a drug to save $50 to $100 million of care. Yes, I do think that will be an emphasis moving forward, especially in populations like muscular dystrophy or spinal muscular atrophy, where they already have some of these treatments out there. And actually at Nemours, we were the first facility in the state of Florida that provided the medication, and I'm blanking on the name. I don't want to mispronounce it, but we were the first pediatric facility in the state of Florida to administer one of the gene therapies to a child who had Duchenne's muscular dystrophy.
That's fantastic. You talked about if you can impact something that early, boy, over a lifespan, the potential savings are enormous. And obviously quality of life.
And then the opportunity cost. I mean, so then the cost back to society too, that now that this, that there's going to be the healthcare cost, but then also the benefit to society, as well as the benefit from a quality of life. You're right.
Fascinating. One of the areas that we talked about a little bit in a call before was population health and quality improvement. And you made a comment that sort of really rung my bell, as I said, which was we really need to look at how we merge these two together. Can you discuss that a bit and your thoughts on that?
Yeah, it's an interesting concept. And, I think I had talked with Alex Koster here at Nemours about this a little bit early on. And I think he had ideas in this area, which really stimulated more ideas for me to start thinking about this. But, I think in the quality and safety space, as a chief quality and safety officer, we tend to draw a line, I think, sometimes between really what we manage from a quality and safety standpoint in the acute care settings, and even in the specialty care settings, from really managing, we don't think of managing populations when we're trying to reduce central line associated bloodstream infections, or we're trying to reduce readmissions. We don't always think, well, if I look at a population, I define that like an asthma population, or geographically, let's say, we just kind of think of, okay, let me look at all cause readmissions and try to reduce those by trying to understand the factors, but we don't necessarily always think about, okay, what are the care milestones within a population? Are they being met? What are the gaps? How are we addressing those? And are those contributing to some of the things that we're seeing from a readmission standpoint? I think one more recently that we just started thinking about, or I started thinking about, was, central line associated bloodstream infections and surgical site infections are two harm indicators that we follow from an acute care standpoint. Those things happen in the ambulatory setting as well. So there are a lot of children out there, whether they have cancer or intestinal failure or on dialysis, that they have central lines, and they are primarily managed in an ambulatory setting. Same thing with a lot of most surgeries are ambulatory surgeries. And so how do we apply this thinking of, okay, in an intestinal failure population, if I'm trying to manage their nutrition, their weight, why don't we consider this as well, right? What is the care of the line? How are we managing that? How are we meeting the different milestones that need to be met within whatever bundles that we're trying to accomplish? And or if we do get an infection, how is that being managed? And how do it's kind of care management and then risk management, right? So we're managing the care and we're managing the risk. And how do we put that into, say, one registry, and we have a care manager who can manage those sorts of things? I don't know that we've thought about it that way in the past, but I do think it's an interesting sort of Venn diagram of, concepts or strategies that we could put together and really probably advance outcomes even further.
Yeah, I think about it from the days of doing population health programs or these disease management programs that we did, children with asthma or adults heart failure or COPD or things like that, or even some mental health areas. And it was really, well, what we're looking at from a quality perspective is did they follow the evidence-based guidelines, but we didn't really go beyond that. And then in the hospital side, you really had that focus on, well, they're here and then they're gone. Right. And now we're trying to sort of bring those worlds together through that continuum. So it would make sense to try to say, how do we integrate that quality component across the board with that population health or care management? Yeah.
Yeah, or we just focus on a measure, right? So in a diabetes population, let's say we just get really hyper-focused on the A1C, or we get really hyper-focused on, trying to keep children, out of the hospital who develop DKA, let's say. But then we miss the larger, if we just managed that group and made sure that they got the care that they needed holistically. So we looked at all the care milestones that somebody who might have diabetes needs. We will accomplish that, right? We'll accomplish whatever those other things that we're trying to do, whether it be drive down their A1C or keep them out of the hospital. But I think sometimes within our space, we get really hyper, especially the those of us who've grown up in acute care settings, get really hyper focused on a measure, right? Instead of the sort of more larger set of measures that we need to be managing as a whole. And the other thing with pediatrics that I would say, we go back to your original question, I don't think there's a lot of care management dollars. And I think some of that, again, maybe is us not being able to describe things as well. So for instance, in Florida, with Nemours, we have multiple sites of care. So we have Pensacola, we have Jacksonville, we have or, Central Florida, and we have GI populations, let's say, in each one of those settings, children with inflammatory bowel disease. I think if we can better describe the care that's being provided to that population across the state in each location and then aggregate it, we could probably create economies of scale, right? Where we could probably take care management dollars and really make them work and provide value back to a payer, insurer, a purchaser to say, and give us an investment and we'll return that to you twofold, just based on, creating these economies of scale across the state. And I think Nemours is probably poised really well to do something like that.
For those of you just joining us, we are in the company of Jared Capouya, MD, the Chief Quality and Patient Safety Officer, a practicing inpatient pediatrics clinician at Nemours Children's Health. Stay tuned for the rest of the story.
And how much of that might be due to the ability to integrate the data or things like that? I know we talk about that across the system, a lack of data integration and hindering the ability to analyze what's really going on in the places. Is that part of it?
I think so, but I don't think that's the biggest barrier. I mean, I think we can get that information. I think we have a good system set up, at least here, there, where we have access, at least for the children seen in our system, we have access to that. Now, when we get into where our children are then seen in another hospital setting, or, we have to rely on an exchange, or, we use the Epic system. So there's a care everywhere function. But I think, yes, I think sometimes it is probably harder to piece some of that together, but I don't think that's the biggest barrier. I think it's probably us telling the story better around what is it that we're trying to accomplish, and how do we organize the work in a way that makes the most sense.
So it's really a workflow issue in a sense, and then looking at it and saying, we're going to go after this. Do you think that this might be something where you talked about, going to a provider and saying, or a payer, and saying, hey, look, we've got this program we'll put in. We believe it's going to create better outcomes, potentially reduce costs. It was funny. I was on a program the other day, and it was that somebody said, yeah, we haven't seen any cost savings. I said, but the outcomes look better, weren't they? So even for the same cost, you were getting better clinical outcomes. Oh, we were. So that is a good reason to do it, Because so even for that, would be something worthwhile. Do you think that might be something you would say you could take to somebody, or is it something you would say, hey, we could put a bundle together around this to price something like that?
Yeah, I think it's probably the former. I think we could probably develop models or use existing models, like I mentioned before, like Healthy Steps, and say, hey, let's do for instance, let's do a demonstration, right? I mean, it's already been shown to work somewhere else. Let's do a demonstration here and follow a cohort for a few years and show, what that return on investment can look like. And it's really a small investment when you think about it, because again, most healthy children do not cost a lot of money to the healthcare system, or it's in the inflammatory bowel disease population. I think you're right. I think it's developing the model and the workflows to show, hey, if we can take care of this in an organized way, and we can sort of bring these discrete populations that are being managed separately and look at it as a whole, we got a critical mass now where we can actually show how we're driving these kids into remission, getting their BMIs up to the right place and having them out of the hospital, because hospital care is extremely expensive. Then I think we can show, okay, yes, if you give us these, per member per month dollars to manage these patients, we will return that in, several fold, because they're not being cared for in an acute care setting. They're really being effectively managed outpatient.
Right. So it's really, when we think about the children, your comment about, not costing a lot. I remember back in the Medicaid days of running a health plan, that 5 to 12-year-old or 5 to 14-year-old was like no premium at all, Right. But early, right, first year kind of stuff. Later on, you had things going on, and it does make it difficult. But within those populations, you do have these really unique illnesses or stuff that are very high cost.
You do. And you're like, when you say early on, it's interesting. You go to the doctor when you're born, you go to the doctor in the first couple of years of life, like 7, 8 times, right? And then after that, it's maybe 7 or 8 times until you're an adult. And so there is a critical time there that I think where you can really influence health outcomes later on, the health of a child, right? And a family for that matter. Because I think there's so many encounters that you have there. And if you can get them to adhere to that, get their vaccines and start instilling some of those things early on, I think you're really going to have a lot of success. And that's where I think an investment would be wise.
Mm-hmm. What about the issue, I don't know if you've talked about this much, but of behavioral health and mental health with children? Anything going on there?
Yeah, and I know you've probably read articles where there's a real increase, whether it be called a behavioral health crisis. I know the state of Colorado actually declared a state of emergency as it relates to childhood behavioral health conditions. It has become an issue in the sense, I think, especially through COVID, kind of unroofed, I think, some of the problems to the public. I think we in children's hospitals have been seeing this for a long time, I think, but I think it's probably become more public in the last few years. But yes, it's some of it's a resource issue where there's not enough places where there may be either providers or just brick and mortar to take care of patients with certain conditions. I think the other thing is that we have to worry about is especially children who have autism, especially nonverbal autism, that when they become adults, there's not always a place to transition some of these children to. So we may have some of those resources in childhood, don't have those in adulthood, and that's a real problem, and that becomes a cost over time. And then there's, obviously the beds. I read a statistic about Florida in terms of beds per need from a behavioral health standpoint. I don't remember the exact number, but it's woefully low, right? And we board children in our emergency departments who need acute resources, crisis resources, and the emergency departments are not the right place for children like that. And so that is another place where an investment in time. I had a graph. When I was at Thomas Jefferson and the master's program there. We was doing some sort of graph of spending over time in healthcare, and like we talk about, it's up near 4 trillion. And as that graph kind of got bigger and bigger and bigger, I had two lines at the bottom, which were essentially static, that just went across as straight lines near the bottom of the graph. And one was behavioral health spending, and the other one was substance abuse disorder spending that just hasn't tracked with overall healthcare spending. And I think that's probably something obviously that needs to be done over time as well. Increased spending.
I know I've seen a fair focus from Nemours and others on social determinants of health and going after that. So obviously children, I think Medicaid has a lot of children in it, and the disparities we see there, I guess that's become a fairly substantial focus of the company and the group.
Yeah. So, and that's not something that we've been intimately involved with, but yes. So there is a survey that patients will get when they come in to the organization, and it focuses on things like food insecurity, housing security, those sorts of things. We also do, to your other question, we also do mental health screenings, especially in the acute and ambulatory settings around, depression risk, suicide risk, those sorts of things. But yes, there are social determinant of health screenings that happen, and resources that get connected to if a need is identified, either through, and it's sort of a tiered approach depending on what the need is, of course. We do have social workers here, and especially in the hospital settings, that help with some of that. And then connections like 211 and other things in the outpatient setting. So.
Excellent. So I should ask you this earlier on, but what made you get into the quality area?
It's a good question. When I came out of training and I went into being a hospitalist, I felt like I was at this vantage point in a child's healthcare, right, where they were sort of between different places. So you had your primary care provider. You had many of them would come through an emergency department. So you kind of got to see the care that was provided in different locations. And then they come into the hospital, then you hand them back off to a primary care provider. And you could see, so a couple things that I noticed was, one, we in the acute care setting had an extreme amount of variability in how we would manage children, right? So somebody coming in with asthma, I may manage them one way, my partner may manage them a different way. In the ER, they're being managed a third way. The primary care provider is managing them a fourth or fifth way. And then we're handing them back off to a primary care provider thinking our way is the best way. And then we hand them back off with, here's what we've put into place. Who knows what's going to happen after that? So that was one thing. So just the amount of variability and just management, I think, was one thing that I saw. And then just having that precipice of like being able to view the care, you could see the dysfunction in the healthcare system, right? And that people would, one, have trouble with coordination. So especially the medically complex, right? They may or may not get the appointments they need. They may or may not get connected with the providers they need. And then they end up in the hospital, right? And so I think that's really what drove me into getting more interested in quality. And my first sort of gig in quality was developing clinical pathways or clinical practice guidelines, getting at trying to reduce some of that variation that in management. And that was really in the hospitalist setting. And then that very quickly grew to our clinically integrated network and really trying to you called it our pediatric collaborative. So it had a primary care arm, it had a hospital arm, and then we had several neonatal intensive care units within our network and healthcare system. And so we would create pathways for all three. And so that was like my next sort of job after that. And then just more and more got into more quality safety, self-educated, and then went and got a master's at Thomas Jefferson in healthcare quality safety management, and kind of went from there. And then my goal after those experiences and really helping a healthcare system identify key measures for pediatric health was, I really was like, I'd really love to run a program at a children's hospital. And then Arkansas Children's opportunity came along. It's a fairly large, 335 bed hospital in Little Rock, and another smaller tertiary care hospital in the northwestern part of the state at about 25 beds and clinics across. I was like, this is great. And there, the mantra was really trying to improve child health. Their state rankings are not very high. They're always usually in the bottom 5 to 10 in the United States. And I was like, who wouldn't want to get behind that, right? And so being able to lead a program there was just amazing. And then having the opportunity to come here has just been great.
Yeah, and obviously I would assume you can really get a chance to see results on a large scale once you begin to implement these and really make a difference.
Absolutely. And I think I shared, I think when we met was at a conference. And one of the things that I think when we implemented, we were very fortunate in Arkansas. I worked with a team at the Clinically Integrated Network. And we were fortunate to get $1.5 million to demonstrate this Healthy Steps program I told you about. And, they already saw just in the first couple of years of that program, no really measurable in the clinics that were participating, about 7 clinics participating, no measurable maternal depression screening happening. Wow. After 2 years, it's over 60%. Same thing with, birth spacing, as we talked about, vaccines, tobacco cessation. So there's a lot of benefits to just in a very short period of time, like you said, over a large scale.
Well, that's fantastic. And thank you so much for coming on. A great way to finish the program, Dr. Capouya. Really appreciate it.
Absolutely. And thank you for having me.
And back to you, Gregg.
And there you have it, folks. That is the last melody on today's broadcast. We want to extend our gratitude to our worldwide listeners for tuning in, and our heartfelt appreciation goes out to Dr. Jared Capouya, the Chief Quality and Patient Safety Officer at Nemours Children's Health, a practicing inpatient pediatrics clinician for more than 20 years. Stay updated with Nemours' groundbreaking work by following Dr. Capouya and Nemours Health on Twitter via @Capouya, and that's CAPOUYA, and @Nemours, that's NEMOURS, respectively. And for more information, head over to www.nemours.org. Stay updated with Nemours' groundbreaking work by following Dr. Capouya and Nemours Health on Twitter via @Capouya, and that's CAPOUYA, and Nemours, NEMOURS, respectively. And for more information, head over to www.nemours.org, especially if you're exploring innovation, pediatric value-based healthcare. If you find our PopHealth Week content as engaging as we do, please show your support. Give us a thumbs up on your favorite podcast platform, share it with your colleagues, and subscribe to ensure you don't miss out on future episodes. Remember, we're live on Healthcare Now Radio weekdays at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for our friends on the West Coast, that's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. From all of us at PopHealth Week, Fred Goldstein and yours truly, Gregg Masters, we urge you to stay safe and stay tuned. Until next time, fare thee well.